Okay, welcome back for those of you who have just watched the A&P review. If not, don't feel bad. Again, it's there if you need it. No, we're never ever going to ask a strict A&P question to you in this class, so if you don't need A&P review, excellent. We're going to move on to the assessment of urinary function. First, we're going to start with student learning outcomes. Again, these are what I expect you guys to be able to do by the end of our 2 days of lecture. I want you to be able to name the 6 primary functions of the kidney. I will give you a hint. Those are back in the A&P review. Identify nursing responsibilities in both some of the pre- and post-test care of patients having urological diagnostic tests. This is not going to be hugely important for me. I do want you to be familiar with the tests that you might see done. For the purposes of this test, I am not going to test you on pre- and post-test care of patients receiving these tests. So there you go. Then I want you to be able to name 5 types of urinary diversion procedures, be able to describe the pathophysiology, nursing assessment, and interventions for patients with pyelonephritis, glomerulonephritis, and nephrotic syndrome. Also describe the pathophysiology, nursing assessment, and interventions for patients with obstructive disorders of the urinary system for things like urolithiasis, hydronephrosis, BPH. Be able to discuss the various types of GU system cancers, so prostate cancer, bladder cancer, renal cancer. Be able to differentiate between acute and chronic renal failure. Differentiate between hemodialysis and peritoneal dialysis. Also discuss the implications of acid-base imbalances. And finally, identify some medications commonly used to treat disorders of the urinary tract. So for medications, I will try to reiterate this when we get to medications in our live lecture, as well as in the last recorded lecture. I am going to be switching to using mainly prototype drugs, so I will try and only give you 1 or 2 medications from any class instead of giving you kind of like this long list to look up. I will give you the most commonly used ones for you to research, and those will be the only ones that I will ever put on an exam for you. So hopefully that helps kind of limit the medication overload that I know many of you have probably felt to some degree or another. So moving on, first we're going to talk about GU assessment. So in any GU assessment, as nurses, we need to be looking at their initial physical assessment. We're going to assess their vital signs, their weight, because we just talked about how blood pressure can be impacted by the renal system. Daily weight, of course, if someone's retaining fluid because they are having kidney issues, we're going to be wanting to look at their initial weight. Later on, we'll be doing a daily weight. We're going to want to assess edema, whether it be facial or generalized edema. Palpate for bladder distension and or tenderness. Again, remembering that the bladder is only going to be palpable when it is very distended. And then visually inspecting external genitalia when necessary. So if someone is complaining of burning or something like that upon urination, that might be a time we would visually inspect external genitalia, not just for ha-has because we're bored though. And then daily assessments are going to include an INO, of course, abnormal flow or change in pattern of voiding. That will be very important if someone is all of a sudden voiding very frequently when they never have before, or all of a sudden having a lot of pain upon urination, or is all of a sudden experiencing retention. And then, of course, our characteristics of urine. Not supposed to be character of urine. That sounds like a really bad, like Hamlet character. Characteristics of urine, so my apologies for that. And then finally, any pain or discomfort that they might be experiencing, either in general if they're having flank or kidney pain, if they're having bladder pain, or if they're having pain upon urination. Other things we need to be assessing, of course, that urinary output. Average output in adults is going to be 1.5 to 2 liters per day. Of course, anuria, these are just some terms that I would be familiar with if I were you guys. Look them up, make sure you're familiar with them in case you see them on the exam so you know what the heck that they mean. Anuria means less than 100 milliliters of urine produced within 24 hours. Oliguria means less than 400 milliliters. So anuria is kind of intimating that there is no urine. Oliguria means that there is low urine. Same thing, polyuria means abnormally high, usually dilute urine output. Poly meaning lots or many. The urge to void, again, I think we reviewed that in that video that was in the A&P, usually happens between about 150 to 200 milliliters in the bladder. That's when it triggers your brain to say, hey, I gotta pee. In children, that's closer to 50 to 100 milliliters. Again, some normal characteristics of urine. In general, the color should be pale yellow to straw colored. It should be relatively clear. A faint smell is pretty normal. Everybody knows what pee smells like probably at this point in our lives for one reason or another. Normal constituents of urine, meaning the things that you're normally going to see in urine if you analyze it, will be urea, uric acid, and creatinine. A specific gravity should be about 1.01 to 1.03. We'll go into a little bit of detail coming up on why it might be one way or another. And then, of course, pH should be about 4.6 to 6.0. So some abnormal characteristics of urine. Again, we just talked about how normal-looking urine should be a pale straw yellow. If it is brown, it might indicate that there is a kidney bleed or some sort of injury to the kidney. Indicates that there is some blood sitting in there and being kind of, I don't want to say digested, but maybe broken down by the urine. Pink or red urine might indicate, again, blood. Usually if it's going to be pink or red, it is probably something that's happening within the bladder, so it indicates a lower urinary tract bleed. A dark amber color can indicate very concentrated urine, might indicate dehydration. Someone has very orange urine, might indicate liver failure, and potentially, if someone is taking the medication pyridium, which we covered in 103, it does turn urine orange. It is always something important to warn your patients about when you are giving them pyridium, because it can be kind of scary to see if you turn around one day and your urine is very, very orange. And of course, white or mucousy, it might mean that there is, of course, mucus or pus, might indicate a kidney or bladder infection. We talked about clarity, how it should be normally pretty clear urine. If it's cloudy, indicates again mucus or pus, which might indicate a urinary tract infection. If white blood cell count or white blood cells are present, again can indicate infection, and you might be able to actually see those. We do call kind of cloudy urine turbid urine. That's a technical term for it, but for our purposes here, we're going to call it cloudy. And again, protein could indicate kidney failure, and that might also make urine fairly cloudy or turbid. As far as odor, if it's strong or foul smelling, it can indicate concentrated urine, dehydration, and potentially a UTI. If urine smells sweet or fruity, it might indicate that there is glucose in that urine as well. So somebody you might see having glucose in their urine might be a diabetic. As promised, here's our specific gravity. So greater than 1.03 for specific gravity indicates concentrated urine, might be an indicator of dehydration. Less than, I don't know why I put 1.013. It's supposed to be 1.010. That means that the urine is very dilute, could indicate overhydration. Maybe somebody just drank a lot of water that day. Might also indicate diabetes insipidus, which I know you guys reviewed with Krista. Again, pH should be in that normal range, 4.6 to 6.0. If the pH is low, it could indicate acidosis, potentially secondary to diarrhea or starvation. A very high pH is kind of a prime environment for developing a urinary tract infection or kidney stones, which we'll talk about. And we talked about the normal constituents of urine. So here are some abnormal things that you might see in urine. Protein, again, indicates some sort of renal disease. Glucose or ketones could indicate diabetes. Red blood cells, leukocytes, could indicate stones. A urinary tract infection could be related to some forms of cancer and trauma. A bacteria, of course, if it's over a certain level, it will indicate that someone has a urinary tract infection or potentially just a very contaminated sample, but usually it's going to be a UTI. Casts is something you will see. on like a lab report, and this can indicate renal disease or infection as well. And then finally, bile or bilirubin, if that is present in urine, can indicate some form of liver disease. I am not going to go into a huge amount of review on some of these clinical manifestations of urinary disturbances. I want you to know that incontinence exists, urinary retention exists, and for our purposes of 107, these are usually going to be a sign that something else is going on. These are going to be a sign or a symptom, as opposed to maybe to how we talked about them in 103 as really kind of being their own problem. They are their own problem. So I'm going to kind of just read these slides. There are a lot of notes in the notes section of these. I will not be testing you on urinary incontinence or urinary retention. I just want it to be a brief review for you, so some of these things seem familiar. So urinary incontinence is essentially the involuntary loss of urine. There are many different types. They include stress incontinence, urge incontinence, mixed overflow, and functional incontinence. Medications, bladder training, potentially a catheter are some treatments we would look at for someone experiencing urinary incontinence. But again, we should also consider the fact that potentially somebody has something else going on that is causing them to be incontinent, as opposed to just being incontinent. Especially when we're talking about med-surg, and it's not just quote-unquote someone getting older and becoming incontinent. If you're seeing someone who's younger and they're having some form of incontinence, it usually indicates something bigger is going on. Same thing for urinary retention. Brief overview. Urinary retention basically happens when there is obstructed flow from something. So the production of urine is normal. So the kidneys are producing urine, it's making it to the bladder, but for one reason or another, it cannot come out of the bladder via the urethra. So the flow is obstructed, which means urine backs up into the bladder where it accumulates. That's when you would probably be able to palpate a bladder. Urinary retention can be acute, meaning it has sudden, very severe symptoms. This might be something after surgery from a kidney stone or a new medication, versus something chronic that is slower, much more mild symptoms. So this might be seen more with a BPH or a nerve impairment, which we're going to talk about. Usually going to be treated with certain medications, catheters, probably surgery if it's bad enough. As far as diagnostic assessment of the GU system, here are some urinary labs that you might see drawn. So of course we have our urinalysis. You'll see it abbreviated as U/A. This test looks for urinary pH. It tests for the presence of protein, glucose, ketones, blood. It will look at the specific gravity. It will see if there's any leukocytes or white blood cells present in the urine. We'll also test for bilirubin and nitrates. Culture and sensitivity, abbreviated C&S. This is used to identify organisms and usually the best antibiotic treatment. So again, you will usually see a UA-CNS ordered on someone who is presenting suspicious for a urinary tract infection. What they're looking for is to see if they have any constituents which might indicate a urinary tract infection. If that comes back as yes, this person probably has a urinary tract infection, they will grow it out and they will do a culture and sensitivity. So they'll grow it out and they will be able to identify the organism that is causing the urinary tract infection. And then they will also perform a sensitivity testing on it, so they will be able to see what antibiotic will be best used to treat it, so we can really tailor treatment for a urinary tract infection. Creatinine clearance is also called a 24-hour urine, so you might see that. That's a real big pain in the bottom. To collect, it has to stay on ice, everything like that. It ultimately determines how well kidneys are excreting creatinine. Normal creatinine clearance is going to be 15 to 25 milligrams per kilogram of body weight within 24 hours. That is not a number you need to memorize. It's just FYI. So if an elevated serum creatinine is present with a decreased urine creatinine, this indicates a decreased kidney function. That little bit of it I want you to understand. but the numbers are not important for me. Finally, urine osmolality. This is used to determine whether the kidneys can actually concentrate urine, and it helps to overall give us an idea of hydration status. Increases in osmolality can indicate dehydration, azotemia, which is a vocab word, so look it up, or chronic renal disease. And a decrease in osmolality can indicate a low sodium diet, excessive water intake, or something like diabetes insipidus. As far as labs that we would look at in the blood, we would look at the BUN. It is the BUN, don't call it a bun. People look at you funny. It's a BUN. Blood urea nitrogen. The normal range is going to be 7 to 20 milligrams per deciliter. This is used to evaluate kidney function and hydration status. An elevated BUN level can indicate some poor kidney function, dehydration, or an increased breakdown of body protein. So you might see this in someone who has been experiencing excessive exercise, severe burn, something like that. Lower BUN levels can be found in severe liver damage, can be found with excessive hydration and protein deficiency. So again, normal levels are going to be 7 to 20 milligrams per deciliter. This can vary a little bit depending on age and sex, but overall that's really going to be the number we'll be looking for. Serum creatinine, again, so this is going to be the creatinine that's present in the blood. This is again used to evaluate kidney function. Creatinine is a waste product of skeletal muscle activity. It is normally produced in fairly consistent amounts and it is excreted through the kidneys. The normal serum creatinine level is going to be 0.8 to 1.2 milligrams per deciliter. More importantly than these two numbers on their own is going to be the BUN creatinine ratio. This will help to distinguish between renal causes and non-renal causes of abnormal values. Levels of BUN in the blood are generally going to be 10 to 20 times higher than creatinine. BUN levels can change due to multiple conditions, whereas creatinine will stay relatively constant. So the BUN result should be divided by the creatinine result. There is going to be a worksheet on Moodle for you to fill out. It's got a whole article on BUN and creatinine, so you'll read that and then fill out the worksheet. That will be your pre-class work that will be due before I see you guys in lecture on Monday. So that will go into much more detail because I could talk about this stuff all day and no one wants to hear that. So review this slide and then review that worksheet, and hopefully we'll go over it again in class Monday morning, and hopefully it'll all make a little bit more sense. It can be kind of foggy though, so I understand that. Take your time with it. So we've talked about urinary labs, we've talked about looking at urine specifically, and now we talked about blood lab values that might indicate some renal function. Now we're going to talk about like radiology and procedures. So something you might see ordered on a patient who is having some sort of renal issue would be a KUB. This stands for kidneys, ureters, and bladders. And bladder. Hopefully they only have one bladder. I'm trying to think I think I actually had somebody who had 2 bladders. Anyways, I digress. A KUB is used to visualize the urinary structures and any radio-opaque stones that might show up. It's a single radiographic view of the lower abdomen, and it is done without any sort of contrast media. An IVP, an intravenous pyelogram. This is again used to visualize kidneys, ureters, and bladder. It's used to detect obstructions, potentially related to tumors or stones. Really not used a whole lot. CT and ultrasound are much more common. Mostly because this involves the injection of an iodine-based contrast. Radiographs are then taken at timed intervals, showing the flow and contrast through the renal system. So again, not too terribly commonly used anymore, at least not in my hospital. Next we have an MRI, magnetic resonance imaging. This can help detect trauma or tumors in soft tissues. It's a non-invasive test using powerful magnetic field to scan radio wave frequencies and form 3D images. And again, it can be done without contrast. CT scan, computed tomography. This is used to determine presence of a cyst, a tumor, or a renal calculi, which is a kidney stone, which we'll talk about. Combination of radiologic and computer techniques. This uses cross-sectional information that indicates density of tissues. Retrograde pilogram. This is used to visualize kidneys, ureters, and bladder during cystoscopy. There we go. I can say it if I'm not looking at it. Catheters are threaded into the ureters during a cystoscopy to inject dye backwards into the kidney. Renal ultrasound. This will help show size, shape, and location of kidneys, ureters, and bladder, and also visualize any obstructions to flow. So this is just a regular old ultrasound. It uses the handheld transducer. It's passed over the skin, producing high-frequency sound waves to create visual images of the structures and, of course, any obstructions. Renal angiography. This is going to be used to assess the renal arterial system and its function, as well as identify any areas of obstruction to blood flow specifically. So not necessarily urine flow. This is going to look at blood flow to the kidneys. It's going to be done under local anesthesia, so catheter will be threaded through the femoral artery and up into the aorta to the renal artery, where a contrast agent will be injected. Finally, cystoscopy. This is used to examine the interior of the bladder. So cysto, bladder, oscopy means looking, right? So cystoscopy, we're looking at the inside of the bladder. This is going to be done under a short-acting or local anesthetic. The cystoscope is passed up the urethra into the bladder. The scope can then be guided into a ureter to extract a stone or to biopsy any lesions that are present in the bladder. Depending on the extent of the procedure, general anesthesia or procedural sedation may be needed. Not terribly common that somebody needs that level of anesthesia, but it does happen. All right, next we have nursing care of GU system patients. So first we're going to start with catheters and tubes. Some of these will be familiar from 103, potentially some of them not so much. So a urethral catheter is also called a straight catheter. We've done that in 103. This is going to be for a one-time or intermittent drainage or to obtain a specimen. So you might hear someone who has some form of urinary retention. They are able to straight cath themselves, and they do it throughout the day at every 4 hours or something. They use a straight cath on themselves. We can also do it 2 people. And sometimes if someone is unable to follow directions, especially someone who's hospitalized, if they're unable to follow directions or we're unable to obtain a really clean specimen from them and we really need to do a UA-CNS on them, we can do a straight cath, one-time thing. We go in, we go out, we get our specimen, and we're done. Foley catheter is probably something we're all fairly familiar with at this point. These are the indwelling catheters. They're placed for continuous drainage, so this isn't something that goes in and comes out. These go in and they stay in for a while. Can be fairly acutely used for checking somebody's, they're on like a strict INO. We might insert a Foley catheter for a few days versus someone who has a Foley catheter kind of forever. If it's in there forever, it will be changed at certain points. It's never something we leave in forever. The catheter itself will be changed in order to help prevent any urinary tract infections. Suprapubic catheter, so suprapubic area. So this goes into the suprapubic area. So it is in the lower abdomen. It goes straight through the abdominal wall, through the bladder wall, and into the bladder that way. So again, it bypasses the urethra altogether. Ureteral catheter. This is something that will be placed or used in procedures to inject contrast or imaging or to access the ureter for intervention. So again, we've talked about urethral catheters, which go through the urethra. This is the ureteral. So this is the ureter that goes from the kidney to the bladder. It's a different location. A ureteral stent. This is going to be a tube that is placed in the ureter to hold it open. This can be done during healing or to facilitate stone passage. So sometimes we'll talk about renal stones and everything, and the stents might make more sense. But if someone has surgery to break up a stone, or they have a lot of little small stones, a ureteral stent can be placed to facilitate the passage from the kidney into the bladder without kind of ripping up that ureter, because that's really what hurts, and it can be really easy to get a stone that is stuck somewhere in there, and then you not only have, like a whole lot of pain, but you also have an obstruction, so fluid can back up because it's no longer going to the bladder, so it backs up into the kidney, which causes a whole bunch of issues. Finally, a nephrostomy tube. This is going to be placed into the pelvis of the kidney through the skin in order to provide drainage of urine directly from the kidney. You will see these in somebody's back in the flank area. And they're really cool. I think probably not so great to have one, but I think they're neat. And again, this will go into an external collection bag, usually much smaller than like a Foley catheter bag or something like that. Urinary diversions. So this goes back to your student learning outcomes. These are some of the things that I want you to be able to identify. We have the cutaneous ureterostomy. This is where the ureters are brought to the surface, usually at the flank. Might have one or two stomas. Let me back up. So urinary diversions. Why do we do urinary diversions? We do these when the bladder is surgically removed, either due to trauma or cancer. If someone has an extensive history of kidney infections secondary to a neurogenic bladder, sometimes it's easier just to take that bladder right out and give them some sort of a urinary diversion. These can help handle the excretion of urine, usually creating an artificial opening, stoma, on the surface of the skin. Diversions can be continent or non-continent. So the cutaneous ureterostomy is going to be non-continent. I have a picture here coming up where some of this stuff might make a little more sense. Let me fast forward there. Let me see if I can find it here. So this is kind of what we're talking about here. So this is where the bladder would be for the cutaneous ureterostomy. Instead of these ureters coming down to meet the bladder, they come out to stomas on the abdomen. From here, some form of collection bag will be present. Let me go back. So now we have an ileoconduit. This is where a portion of the ileum is used as a tube or a conduit to a stoma. Go forward, let me see if I can find it. So here, again, we have our kidneys and our ureters. Bladder would normally be down there, but now these are being connected into part of the ileum. A section of the ileum is removed, and then the remaining ileum is rejoined by an anastomosis. One end of the ileal segment is sutured together, and the other is going to be brought out through the abdominal wall, creating the stoma. The ureters are then attached to the ileoconduit so that urine can flow through the conduit to the outside. So something like this would allow for one stoma instead of two. So again, if you have, if you had some trauma or something, you had your bladder removed, and you only had one kidney, or sometimes they will be able to connect one kidney's ureter to the other, and then you would only potentially have one stoma. This is another way to only have one stoma. Next, we have the sigmoid conduit, because I can't pronounce that word, I'm not even going to try. These are pretty rarely used because they have a high potential for incontinence. This is where ureters are attached to the sigmoid colon, and then the urine is excreted with the stool. So if you can think about it, you're adding, as much urine as somebody produces in a day, you're adding that to the stool. High potential for incontinence, so it's really not going to be used very much anymore. I guess sometimes you got to do what you got to do, but not too common. As far as a continent urinary diversion, we have the Indiana pouch. So this is where, let me see if we have a picture of it. I think we can kind of call it something like that. I think that's going to be mostly what it looks like. So typically here, either the ileum or a terminal ileum combined with the extending colon is going to be used for a continent urinary diversion. These segments are fashioned to create a spherical shape and used as a reservoir, kind of like a bladder, but not really. The spherical shape has an increased capacity and decreases the pressure inside by allowing the walls of the pouch to expand, preventing problems such as high pressure reflux and eventual renal failure. A one-way valve mechanism is going to be created at the external stoma, through which catheterization can be performed intermittently throughout the day in order to empty the internal pouch. So with something like this, that's why they call it continent. Doesn't actually mean someone can urinate out of it, but it does mean that there is no need for an external storage system. So no bags for something like that. Finally, this is just something I want you to be aware of. Neobladder, it's going to be created using the intestine. It's really pretty cool. I've never seen it done. So this is going to be a bladder substitute or a neobladder. These can be created using a portion of the patient's own intestine. They are used when the sphincter is intact and there is no cancer in the urethra or the neck of the bladder. Of course, the advantage here is going to be normal micturition, normal urination. Examples include the cock pouch. The Indiana pouch is a form of this. And the ileal neobladder is another word or another type. Emptying of the surgically created bladders is accomplished by tightening the abdominal muscles. So again, really kind of allows for this person to almost be completely continent again, just different. Pretty cool. Never seen it done, but still cool. And there's back to our picture. So here are just some nursing diagnoses that I would love for you guys to be familiar with. So just think about all of the different things that we might see when we're talking about something wrong with the GU system. So we have impaired renal function, kind of a gimme, right? Might be related to renal ischemia. Excess fluid volume, we've established that the kidneys help regulate blood pressure and fluid. So, of course, if that system isn't working correctly, we absolutely have the potential for fluid volume overload, secondary or related to compromised regulatory mechanism, risk for electrolyte imbalance related to renal dysfunction, risk for decreased cardiac output related to increased afterload or preload. We have the risk for ineffective peripheral tissue perfusion. This one's kind of a reach, especially since we haven't got to hemodialysis yet, but any interruption in like a AV fistula access. So if someone starts bleeding a lot from their AV fistula, which we'll talk about, they might be at a risk for ineffective peripheral tissue perfusion. And then we have a risk for infection. Anything that causes an invasive procedure, which is pretty much everything we just talked about, right? Someone's going to be at a higher risk for infection. So any surgery that someone is having done, any procedure that someone is having done, anytime we're introducing a catheter to somebody. So really a whole lot of things can cause a risk for infection, so just be really aware of it. Anytime we're going into the body with anything, they are at a risk for infection. Some other nursing diagnoses to be aware of: deficient knowledge related to potentially insufficient information, insufficient interest in learning, insufficient knowledge of resources, or misinformation presented by others. So this might be, deficient knowledge is going to be a big one, especially in acute, pretty much anything for the renal system. If someone is newly diagnosed with acute kidney injury or newly diagnosed with chronic kidney disease, they are probably going to have a knowledge deficiency through no fault of their own, insufficient information. So what is our job as the nurse? we got to give them sufficient information, right? Other diagnoses: risk for situational low self-esteem, related to alteration in body image or loss of function. That might be a big one. Just having the ability to go in the bathroom and pee, we take it for granted, but when you can't, or when you have to self-cath, or when you have a catheter bag, or you are incontinent, anything like that can absolutely impact somebody's low self-esteem. And of course, sexual dysfunction, secondary or related to alteration in body function or structure. So depending on what this person has going on, it can be really hard to feel good about yourselves or feel like you want to have relationships with anybody if you have a catheter. So, of course, as nurses, we're going to do everything we can to support this person and help them work through their problems. And that's it. 36 minutes, give or take. Not too bad for recording number 2. So last recording is going to be on acid-base balance, which is riveting stuff. I will see you there, and I'll see you in live lecture. Thank you.